I'm going to discuss about the investigation and management of the NEC from the so specific learning objectives for today's presentation will be the diagnostic approach, the selective investigation and the interpretation, different management approaches for the management of necrotizing enterocolitis, and decision making regarding a particular approach. So as we know, the diagnosis has to be made as per the clinical laboratory and imaging studies. So for the clinical findings of early NEC will be vital instability first. First and foremost, there will be change in the vitals, temperature instability. There will be high heater output when you're seeing the patient on daily basis. So you can suspect about the early NEC. There will be lethargy, apnea, bradycardia, hypoglycemia, and a mild clinical findings like abdominal distension, mild abdominal distension. Baby will have high residue, decrease feed intolerance, and there'll be they may be bleeding per rectum. It may be just occult blood or a gross blood, and mild abdominal tenderness may also be there. If we go further to the advanced NEC, apart from the vital instability, the baby may develop hypotension, shock, bradycardia, severe apnea, and severe respiratory distress. Clinical findings will be abdomen will be more distant, and abdominal wall edema, erythema, definitive tenderness may be seen. They may be fixed or mobile mass. You may feel abdominal wall crepitation when there is a pneumoperitoneum and it entered into the abdominal wall. Ascites, and in cases of male baby where there is patent processus vaginalis, and if there is a perforation in the abdomen, you may find a discoloration of abdomen. In laboratory findings, we see that total leukocyte count, which may be less or more. There will be neutropenia. Absolute neutrophil count may go to less than 1500, and there will be greater immature cells. Thrombocytopenia will be there, less than 1.5 lakhs per cubic mm, and it is being studied that if platelet count are less than 10,000, or if there is more of rapid drop, it indicated of poor prognosis. Platelet count, if there is a drop of less than 10,000 within first 3 days of diagnosis of NEC, then you should definitely consider surgery. NEC tried, as we all know, metabolic acidosis by carb if less than 16 and pH less than 7.25, serum hyponatremia and thrombocytopenia. It is on the laboratory findings. Early identification of surgical intervention has been studied in one of the uncontrolled RCT, and they found that out of these 7 criteria, if 3 are positive, then you should consider surgical intervention for the better outcome. And they considered metabolic acidosis, bandemia, hyponatremia, platelet count less than 50,000, mean arterial pressure less than gestation age, or if patient is on any pressors, and absolute neutrophil count less than 2,000, and positive blood culture within 96 hours of diagnosis. Next slide, please. Few other diagnostic indicators, as we know, the CRP and stool for occult blood and reducing substance. This is because of mucosal injury. When the carbohydrates are not getting absorbed, so they will go to the colon, and it will get fermented over there. So you'll get stool for reducing substance positive, and once it is fermented, the D-lactate levels will rise, which will excreted by the kidney. So urinary D-lactate will be positive, and same with that fermentation, hydrogen ion breath test will be positive. And in one of the studies, they suggested that hydrogen ion test in breath test rules out NEC in 99% of the cases. Calprotectin, as you know, is a calcium binding protein, and it can be present in stool, is a marker of gut inflammation. And next slide, please. As my colleague discussed, the intestinal fatty acid binding proteins, they are also marker of the intestinal injury, and it can be positive in the serum. As it is excreted in the urine, it can be urinary IFAB is also positive. and its significance with this creatinine concentration is more of the prognostic marker. In one of the studies, next slide, please. In one of the studies, urinary intestinal fatty acid binding protein, liver fatty acid binding protein, and trefoil factor 3 and serum amyloid A, they took all these in collaboration, and they find it more. They found that it is good indicator in detecting of early NEC and for the prediction of the disease, whether we need a surgical intervention or not, and the progress of the disease. Microbiological tests like bacteriology, bacterial culture, stool culture, peritoneal fluid cultures, they are variable, and it's more depends upon the local NICU local NICU. Now we come to the imaging in NEC. X-rays in NEC is more common and to be done. Next, please. Next slide, please. So as we see here, can you see the slide X-ray fully, please? Early signs will be dilatation of bowel loops, and there'll be bowel wall edema. And next slide, please. As the NEC go into the advanced, as NEC comes well established, there will be mucosal injury, and the air from the intestine will enter into the submucosal plane, and you'll see the pneumatosis intestinalis. And if it further invade the bowel wall, then you find air in the subserosal plane. So you will see the crescents in the bowel wall, as you see in this X-ray. Yeah. So one more click, please. So here it shows this is the branching pattern in the liver, and that is the portal venous gas. There are crescents also, and there are so bubble appearance also here, which is suggestive of pneumatosis intestinalis. Next slide, please. If you once the intestine perforates, the air will come into the peritoneal cavity, and you will get signs of pneumoperitoneum in the X-rays. If the baby is in supine position, which is most of the time, so you'll get free air over the liver, and if you get significant lucency over the liver, it is suggestive of pneumoperitoneum, as you see in this X-ray. If it is not possible to get an erect X-ray, which is mandatory for detecting pneumoperitoneum, so you can get a lateral decubitus film, and in this free air over the liver can be seen, which is suggestive of pneumoperitoneum. You can also see air in between two lumens of the bowel, which is regular sign, and that is also indicative of pneumoperitoneum. Next slide, please. So apart from the X-ray, ultrasound also played its role in diagnostic, and is a good tool. So when the findings are like, if you've seen a probe tenderness, that is also definitive of tendering abdomen, and there is some inflammatory pathology is going on, you can detect. In initial NECs, there will be bowel wall edema, and later on, as you can identify the thinning of bowel wall. You can find out the reduced peristalsis on ultrasound. There will be altered vascular state. In initial stage of NEC, it will be hypervascular, while in later it may be hypovascular. Pneumatosis intestinalis can be identified very beautifully on ultrasounds, and you will find hyperechogenicities in the bowel wall. Portal venous gas bubbles in the liver, free air and free fluid, they all can be identified on ultrasound. As you see in this slide, pneumatosis intestinalis, it looks like a beaded pattern in the bowel wall. Next slide, please. This is also the picture of pneumatosis intestinalis, all these microechogenicities in the bowel wall. So management is medical and surgical, and it all depends upon the staging of the NEC. Stage 1 is suspected, 2 is definite, and 3rd is advanced. And 3rd is the stage where we go to the, where we go for the surgical management. Next slide, please. So non-operative management basically is indicated if there is no intestinal necrosis and if there is no perforation, we should definitely go for the non-operative management. And the common approach for the non-operative management is that we have to give gut rest, we have to keep patient NPO, gastric decompression with infant feeding tube, intravenous fluid to be started, and TPN to be considered if in cases of stage 2 NEC and above. Blood investigations to be sent, initiate antibiotics covering gram-positive, gram-negative, and anaerobic coverage, and as per the NICU nosocomial flora. Empirical antifungus can be used in cases if we are expecting a prolonged duration of antibiotic, and close clinical observation is must, because at any stage patient may land up from stage 1, stage 2 to stage 3. So roughly for stage 1, antibiotics and NPO for 3 days will suffice, while for stage 2 where it is a mild disease, NPO for 7 to 10 days is okay, and for stage 2 you may need a prolonged NPO for 10 to 14 days, and stage 3 where you need a surgical intervention. Next slide, please. So surgical intervention, as I said, when do we need, if in cases of perforation, if there are signs of gangrene, and if there is continued clinical deterioration while continuing on medical management. Signs of perforation, as we find out, we see pneumoperitoneum if it is there, if there is positive paracentesis, which can be done at bedside and as an important tool, and we must not ignore. And ascites if it is there, especially echogenic ascites or hemorrhagic ascites, and peritonitis. Signs of peritonitis. So all these indicate the perforation. And if there is local peritonitis, if there is fixed persistent bowel loop, which we can see on the repeated X-ray of 24 hours apart, and if there is portal venous gas, which is an ominous sign and associated with the full thickness bowel necrosis. And in such cases, urgent exploration is required. Next slide, please. So surgical management in terms of primary peritoneal drainage and laparotomy is indicated. Next slide, please. Primary peritoneal drainage, there is a lot of controversies between whether few studies have shown that primary peritoneal drainage and laparotomy, which is better, and whether they have the same outcome. So few studies have shown that short-term outcome in terms of hospital stay, in terms of morbidity and mortality, is almost equal. But recent meta-analysis, which was done in 2021, which showed there is increased morbidity with the peritoneal drainage, but still controversy is going on that about the selection of patient which they took for the primary peritoneal drainage. In short, and what is concluded is that in sick babies, in extremely low birth weight babies with perforated NEC, primary peritoneal drainage should be done, and where you cannot take these babies to OT. So the benefit is that it can be done at bedside and under local anesthesia, and you can use it will give relief to the patient for the current peritonitis which is going on. You can use a Penrose drain or glove drain can be used, and much of the expertise is not required for putting this peritoneal drain. Laparotomy can be done in cases of focal disease. We can come out with resection, anastomosis, and a stoma. In case of multifocal disease, we have to do either multiple stoma with multiple resection, or a high-end stoma, and then give a second look of surgery. In case of multiple perforation, small perforation, you can just close those small perforation and then put a drain and wait. And if there is a novel technique that avoiding multiple stomas, you can just resect the necrotic areas and clip all those necrotic areas and close the abdomen, and after 48 to 72 hours give a second look for the surgery, second look laparotomy to be done, and to see if you can do the bowel continuity. So this can avoid multiple enterostomies. In this slide we can see that there is a well-defined necrotic bowel is there, but apart from it there are multiple areas of the bowel which are compromised. Next slide, please. In this also we can see multiple small patchy necrosis of the bowel, superficial necrosis, along with a large perforation. So complication, as my friend had already discussed in few complication, I'll go to few like complication related to the TPN. Prolonged TPN is cholestatic liver disease. It can recurrent necrotizing enterocolitis in 4 to 6% of cases. Complication related to the short bowel syndrome, in which less than 25% of the viable bowel is there, or less than 50% of the viable bowel is there. So this is the main complication which cause reduced, which cause malabsorption, and this has to be addressed. So although short bowel syndrome requires prolonged TPN, but there are few lengthening procedures also which can be done. Next slide, please. Next slide, please. So as this in longitudinal intestinal lengthening and tailoring, in this procedure, we divide the mesentery in between, and then we divide the bowel in between from in between the mesentery. So same mesentery will supply, and then we anastomose these two half of the bowel to each other to lengthen the intestine. Next is a serial transverse enteroplasty. This also can be done, but in neonates the problem is that the diameter of the gut is very small, so it is difficult. And secondly, this will require a prolonged, a long anastomosis if we do multiple. So chances of leakage is more. Anastomotic dehiscence is more. Intestinal transplant is also can be addressed in these cases, and although there are post-transplant complications also, it has been done in few centers in India like Apollo Hospital in Chennai, Hyderabad, and Fortis. But in a very small baby, it is difficult to do. So for till some duration, we have to maintain the baby on TPN and few other measures. Complications related to stoma are we address very commonly, and this is the peristomal excoriation, which is most common, and it is more in cases of stoma done for NEC, because most of the time it is small bowel. So it excoriates the skin around, and you can use a zinc oxide paste or cream, or you can use even coconut oil to protect the skin around. High output stomas lead to malabsorption of the electrolyte imbalance and short bowel syndrome, and prolapse, retraction, and stricture are also common. So stoma closure in cases of high output stomas, and because these are small bowel, in case of malabsorption, you can consider any time after 4 weeks. But you have to give 4 weeks to the patient to get the bowel heal properly before closing the stoma. And before closure of stoma, the patency of the distal bowel must be confirmed. This can be done by doing the contrast X-rays. There are studies showed a significant neurodevelopmental delay and impairment in cases of the surgical as well as in the non-surgical NECs. Next slide, please. So outcome is improved as the critical care is improved, and it depends upon the stages and extent of the disease. And pan involvement, the outcome is poor. Babies who are less than 1,000 gram is nearly 100% mortality, because more likely they used to involve pan involvement of the Good. This is the Radiopedia app. You can check on for the finding like X-rays. I think most of us uses that. So take-home points are that clinical findings along with the specific laboratory and radiological findings helps in staging and the line of management of NEC. Early detection and timely intervention is important for the better outcome, and identify the need for surgery and the type of surgical intervention need for your patient. And clinical outcome depends upon the extent of the disease. And we need further refined studies to identify the early detection of to early detect NEC so that we can give better outcome to our patients. Thank you so much.